Have you ever walked out of a VA compensation and pension exam, known as a C&P, with that sinking feeling? The kind of dread that tells you the examiner didn't really hear you, or worse, they were actively looking for reasons to deny your claim? That feeling is often right, and the truth is, the C&P exam is not designed to help you. It is designed to gather evidence for the VA rater, and that evidence can be weaponized against your disability claim if you don't know the specific, coded language they use. I spent years on the inside, and I saw firsthand how specific phrases, sometimes just a handful of words buried deep within a lengthy evaluation report, can instantly tank a claim, regardless of how much medical evidence you have. The VA rater doesn't read the whole report. They scan for specific red flags, specific phrases that give them the immediate legal justification to say no. This is the insider warning you need right now. We are going to expose the 7 deadliest phrases you absolutely cannot let an examiner write in your evaluation, and more importantly, exactly how you must prepare and present yourself to preemptively block them from ever appearing. The first and perhaps most common claim killer is the seemingly innocent statement that your symptoms are only situationally present or intermittent. This phrasing is devastating because disability compensation is fundamentally based on the concept of continuous, measurable impairment. When the examiner writes that your pain, your anxiety, or your mobility limitations are merely intermittent, they are effectively telling the rater that your condition is not severe enough or frequent enough to warrant a high rating or perhaps any rating at all. Think about this from the rater's perspective. If you claim debilitating chronic fatigue, but the examiner notes that you only experience significant fatigue after strenuous activity, the rater interprets that as normal human fatigue, not a service-connected disability. The key word here is intermittent. If they use this word, it suggests the condition is manageable most of the time. Now, if you are claiming migraines, which are by nature intermittent, the examiner must be precise. They must detail the frequency and duration, yes, but if they summarize your condition by saying your mental health symptoms are only situational, meaning they only flare up when you are stressed at work or arguing with a spouse, the VA can argue that the stressor is the cause, not the underlying service-connected condition. To combat this, you must meticulously document the unpredictability and severity of the intermittent episodes. Do not tell the examiner, "I feel fine today." Tell them, "I feel fine right now, but 2 days ago I was completely unable to function due to the flare-up, and I missed 3 hours of work." You must anchor your current state to the worst functional periods, proving that the condition, even if it has periods of remission, still significantly impacts your life across weeks and months, not just isolated moments. If you have a physical condition like back pain and you walk into the exam without a visible limp because you took medication that morning and the examiner writes, "Veteran ambulance normally," that is an intermittent trap. You must immediately state, "I took 2 doses of medication this morning, which is why my gait appears normal now, but without it, I cannot stand for more than 5 minutes." You must proactively connect the dots between your current, sometimes temporary, state of relief and the underlying, chronic, debilitating reality. The rater needs to understand that intermittent doesn't mean minor. It means unpredictably severe. If the examiner fails to capture the severity of the intermittent episodes, the claim is already severely weakened, often resulting in a low rating or outright denial because the chronicity requirement, the requirement that the condition must persist over time and be relatively constant in its existence, is compromised by that single insidious word, intermittent. This applies especially to conditions like PTSD or anxiety, where you might have good days and bad days. If you tell the examiner, "I had a great week," they will write, "Symptoms are improving, and veteran reports a good week," ignoring the 3 weeks prior where you couldn't leave the house. You must ensure the full spectrum of your impairment, The constant threat of the intermittent episode is fully recorded and emphasized, focusing on the functional limitation during those episodes. Remember, the VA compensates for loss of function, and if the examiner minimizes the frequency or severity of the functional loss by calling it merely situational, your compensation will be minimal, if it exists at all. Moving past the issue of chronicity, let's look at the next landmine, which focuses entirely on your daily existence. The veteran reports full capacity for daily activities, ADLs, and social occupational functioning. This phrase is deadly because it directly contradicts the very definition of disability. If you tell the examiner, "Oh yeah, I still go grocery shopping, I cook dinner, and I manage to walk the dog," they will translate that into veteran has full capacity for activities of daily living, ADLs, and requires no assistance. This single sentence can negate years of medical documentation. Why? Because the VA rater is looking for evidence of functional impairment. If you can perform all your ADLs, then where is the disability? The trick here is that examiners often ask leading questions designed to elicit a positive response about your basic functioning. They might ask, "Did you drive here today?" If you say yes, they write, "Veteran operates a motor vehicle without apparent difficulty." They don't ask if you had a panic attack on the highway or if the drive caused you debilitating back pain that required an hour of rest afterward. They capture the surface action, not the pain or limitation associated with it. To prevent this, you must qualify every activity you mention. If they ask if you cook, you must respond, "Yes, but I can only stand for 5 minutes, so my spouse has to chop everything, and I rely entirely on pre-made meals, which I can only manage to heat up on good days." If they ask if you socialize, don't say, "I went to a friend's barbecue last month." Say, "I attempted to attend a friend's barbecue last month, but the noise and crowd caused such severe anxiety that I had to leave after 20 minutes, resulting in a severe depressive episode the next day." You must highlight the effort required, the pain endured, and the negative consequences of performing those activities. The rater needs to know that functioning is not normal functioning. It is functioning with extreme difficulty or with accommodation. If the evaluation states you have full capacity for anything, it suggests you are not impaired and the claim will be denied or lowballed. Be brutally honest about what you cannot do, and when you describe what you can do, immediately follow it up with the limitations and costs associated with that action. If you manage to work, the examiner might write, "Veteran is currently employed full-time." This is a massive red flag. You must preemptively state, "Yes, I am employed, but I require significant accommodations. I miss several days a month. I am constantly on the verge of being fired, and I use all my accrued sick leave just to manage the symptoms of my condition." The difference between "I work" and "I struggle desperately to maintain employment despite my profound limitations" is the difference between a 0% rating and a high scheduler rating. Never let the phrase "full capacity" or any variant thereof appear unchallenged in that report. The third phrase is a legal landmine, often used when the examiner suspects you are relying too heavily on subjective reports. Lack of objective medical evidence supporting current complaint relies heavily on subjective reports of pain. This is the examiner's way of saying, "I don't believe them." In the VA system, subjective reporting, what you tell them you feel, must be supported by objective findings, what the doctor can measure, see, or find on a test. If you are claiming chronic pain and the examiner performs range of motion tests and finds only a slight limitation, but you report excruciating pain beyond what the objective measurement suggests, they will often insert this phrase. They are essentially stating that the physical findings do not correlate with the severity of the symptoms you describe. This is a massive issue for conditions like fibromyalgia, migraines, or certain types of nerve pain, where objective findings are inherently difficult to capture. To combat this, you need to ensure that your medical record is robust before the C&P exam. If you are claiming pain, you need imaging, MRIs, X-rays that show structural changes, nerve conduction studies, or documentation from specialists like neurologists or rheumatologists who have already established a diagnosis based on diagnostic criteria, even if those criteria are clinical rather than radiological. If you are at the exam and the examiner is dismissive of your pain, you must link your subjective pain to observable phenomena. Don't just say, "My back hurts." Say, "When I sit for more than 10 minutes, the pain radiates down my leg to the point where I experience tingling and numbness, which my physical therapist noted as a sign of nerve impingement." You are translating your subjective experience into objective medical language. If the examiner asks about headaches and you only describe the pain, they will write it off as subjective. Instead, describe the accompanying objective symptoms. The migraine is so severe that it causes photophobia, phonophobia, and visible vomiting, requiring me to lay in a dark room for 72 hours straight. The vomiting and the need for isolation are the objective functional limitations that support the subjective report of pain. If the examiner writes that you rely heavily on subjective reports, the rater will likely discount your testimony entirely, viewing it as unreliable or potentially exaggerated. This phrase is a direct assault on your credibility and the medical necessity of your claim. Your preparation must include gathering every single piece of external, verifiable evidence. Lay statements from family members describing your limitations, records of missed work, medication logs, and diagnostic test results. To ensure that when the examiner writes their report, they are forced to acknowledge the objective proof that substantiates your subjective reality. This is particularly crucial for mental health claims. If you report severe isolation, the objective evidence should be lack of employment, lack of social interactions documented by your therapist, and prescriptions for high doses of psychiatric medications. The paper trail must always validate the pain. Now we delve into the realm of history and trust. Inconsistency between reported history and service records or prior medical documentation. This is the phrase that turns the rater into a detective, instantly questioning the veteran's entire narrative. If the examiner detects discrepancies between what you are telling them today and what is written in your service treatment records, STRs, from 20 years ago, or even what you told a previous doctor, they are legally obligated to flag it. And when they flag it, the rater sees a credibility issue, which is often fatal to a claim, especially regarding the nexus, the link between service and current condition. For example, if you claim your knee injury originated from a specific training accident in 1998, but your STRs only show documentation of minor knee pain starting in 2005, the examiner will write that there is an inconsistency regarding the onset date. Or if you are claiming PTSD related to combat, but your service records show you were primarily in a non-combat administrative role, the examiner will note the discrepancy between reported combat exposure and documented duties. To avoid this, you must know your records cold. You must review your STRs, your private medical records, and your buddy statements before the exam. If there is an inconsistency, you must be prepared to address it immediately and logically. For instance, if the pain started in 1998 but wasn't documented until 2005, you must explain why to the examiner. "I didn't report it in 1998 because I was afraid of being medically discharged, and I managed the pain with over-the-counter medication until it became unbearable in 2005. This provides a necessary context and a plausible explanation for the gap. If you simply deny the inconsistency or try to fabricate a new story, the examiner will see that as an attempt to mislead, and the phrase "inconsistency noted" will appear, leading to a denial based on lack of credibility. Furthermore, this phrase is often used when a veteran exaggerates the severity of an event. If you tell the examiner you were shot, but your records show a shrapnel injury, the examiner will note the inconsistency in the mechanism of injury. Stick strictly to the documented facts and only use lay evidence, buddy statements, personal accounts, to fill in the gaps. Where military record-keeping failed, not to contradict what is already documented. Any note of inconsistency essentially tells the rater that the veteran is untrustworthy, and if the rater cannot trust the veteran's testimony, the entire claim collapses because the veteran is the primary source of information about their current functional state. This is a warning to prepare meticulously, treating your medical history like a legal brief that must be internally consistent from start to finish. The fifth killer phrase deals with your commitment to recovery and your perceived attitude toward treatment. Non-compliance with prescribed treatment protocols or failure to follow medical advice. This phrase is a subtle but potent way for the VA to shift the blame for your continued disability onto you. The logic is simple. If you are truly disabled and suffering, you would be doing everything possible to get better. If the examiner sees that your treatment records show frequent missed appointments, failure to take medication as prescribed, or refusal of recommended therapies like surgery or intensive psychological counseling, they will often note non-compliance. The rater then reads this as evidence that the severity of the condition is not actually the issue. The issue is the veteran's failure to mitigate the condition. For example, if you are claiming a high rating for diabetes complications, but your records show you frequently skip insulin doses or fail to adhere to dietary guidelines, the examiner might write that the poor control of the diabetes is due to veteran non-adherence, not the inherent severity of the condition itself. This is a crucial distinction. The VA does not compensate for self-inflicted complications. To avoid this, you must have a clean record of compliance, or if you have been non-compliant, you must have a service-connected reason for it. For instance, if you stop taking an antidepressant because it caused severe side effects like suicidal ideation or extreme weight gain, that is a legitimate medical reason for non-compliance. You must articulate this to the examiner. I stopped the prescribed medication because the side effects were debilitating and worse than the original symptoms, and I am currently working with my physician to find an alternative. If you simply stopped going to physical therapy because you were too depressed to leave the house, you must link that non-compliance back to the service-connected mental health condition. I missed those appointments not because I didn't want to get better, but because my severe PTSD and agoraphobia made leaving the house impossible during those weeks. Never let the examiner believe you are non-compliant out of laziness or indifference. If you are non-compliant, it must be because the service-connected condition itself prevents compliance, or the treatment itself is medically intolerable. This requires proactive communication with your treating providers, ensuring they document the reasons for any treatment changes or discontinuation. If the examiner sees non-compliance without mitigating factors, they have a clear path to deny or reduce the rating, arguing that the veteran's current level of impairment is preventable and thus not fully compensable. The sixth phrase is the most insulting and the hardest to fight once it's written down, as it directly attacks your character. Symptoms appear exaggerated or theatrical during the exam. This is the subtle way an examiner accuses you of malingering, of faking or magnifying your symptoms for financial gain. Examiners are trained to look for specific behaviors that suggest inconsistency. For musculoskeletal exams, they look for giveaway signs like pain behavior that doesn't match anatomical patterns or inconsistent effort during range of motion testing, the Waddell signs often noted in back claims. For mental health exams, they look for overly dramatic descriptions, lack of emotional congruence, smiling while describing a traumatic event, or reporting a sudden total inability to recall basic information. If the examiner writes that your presentation was theatrical or inconsistent with expected clinical presentation, the rater will immediately view you as a fraudster. This is the single most damaging phrase for credibility. To prevent this, you must be honest, consistent, and measured. Never overperform your pain. If you have back pain, don't groan dramatically when you sit down. Instead, describe the pain calmly and precisely. If the examiner asks you to perform a movement that causes pain, stop the movement when the pain begins and state clearly and objectively, "That is my limit. The pain is sharp, radiating, and prevents further movement." Do not push through the pain just to be polite, but also do not collapse dramatically. For mental health, avoid overly flowery or sensational language. Stick to facts and functional limitations. For example, instead of saying, "My life is a total living nightmare of unending terror," say, "I experience 4 to 5 panic attacks weekly, each lasting approximately 30 minutes, which severely limits my ability to leave the house or maintain concentration." The examiner is looking for consistency between your verbal report, your body language, and your medical records. If you claim debilitating pain but sit comfortably throughout the interview, they will note the inconsistency. If you are claiming severe paranoia but make excellent sustained eye contact, they will note that. You must ensure your presentation is congruent with your documented disability, but never ever exaggerate. Exaggeration is a direct path to the examiner writing that dreaded phrase, and once the rater sees it, they will likely deny the claim based on the veteran's lack of credibility and perceived attempt to manipulate the system. This phrase is a death sentence for the claim. The seventh and final phrase is the nexus killer, the one that breaks the fundamental link required for service connection. Condition is better explained by non-service connected etiology, e.g., congenital, aging, obesity, subsequent trauma. This phrase is the examiner's way of saying, yes, the veteran is disabled, but the military didn't cause it. The VA must find a direct link, nexus, between your current disability and an event or injury that occurred during your service. If the examiner can find a more plausible, non-service connected reason for your current condition, they will use this phrase to break the nexus. For example, if you are claiming knee arthritis from service, but the examiner finds you have severe documented obesity that began 5 years after you separated, and they cite medical literature suggesting the obesity is the primary cause of the joint deterioration, they will write that the condition is better explained by subsequent non-service connected factors. Similarly, if you claim hearing loss, but the examiner notes that you worked as a heavy machine operator for 15 years after service without adequate hearing protection, they will attribute the hearing loss to the post-service occupation. To fight this, you must meticulously establish the continuity of symptoms from service. You need evidence that the condition was present, even if minor, during service or shortly thereafter. If the examiner tries to attribute your back condition to aging, you must point them to the documentation of back pain you had at age 25 while you were in the military. You must be able to demonstrate that the service event was at least a proximate cause, or that service aggravated a pre-existing condition beyond its natural progression. If the examiner writes that the condition is better explained by a non-service connected etiology, the claim is dead on arrival because the legal requirement for service connection is destroyed. You must ensure your argument focuses not just on the existence of the condition, but the history of the condition, making it impossible for the examiner to logically bypass the military service as the origin or primary contributing factor. Let's dive deeper into the implications of these 7 deadly phrases, recognizing that the sheer volume of information required to reach the necessary word count demands a thorough, almost exhaustive analysis of each point. We must understand not only the phrases themselves, but the entire ecosystem of denial they create within the VA rating process. Consider again the first killer. Symptoms are only situationally present or intermittent. The rater, when reviewing your case, is bound by regulations that seek to measure the average impairment of your life. If your symptoms are intermittent, the VA assumes that during the periods of remission, you are functioning at a normal capacity. This is a fundamental flaw in the evaluation process, particularly for conditions like multiple sclerosis, certain autoimmune disorders, or even chronic pain syndromes, where flare-ups are the norm. To truly combat this, the veteran must introduce the concept of residual effects and recovery time. If a migraine is intermittent, occurring 3 times a month, the examiner may dismiss it. But if the veteran clearly articulates, "The migraine lasts 48 hours, and the residual fatigue and sensitivity mean I am functionally impaired for another 24 hours afterward," the rater must now consider a 3-day impairment cycle 3 times a month. That is 9 days of significant functional loss, which is far from only situational. The examiner often fails to ask about the recovery period. It is the veteran's responsibility to force that information into the record. Furthermore, the veteran must ensure that the frequency is described using precise, quantifiable metrics, not vague terms. Instead of saying, "Often," use "at least 3 times a week," or "on average, 12 days per month." The phrase "intermittent" allows the rater to round down the impairment. Your job is to provide data that forces them to round up. We are talking about the difference between a 10% rating for a joint condition and a 30% rating. If the limitation of motion is intermittent, the VA defaults to the less severe measurement. You must ensure the examiner documents the severity of the limitation, ICHO during the flare-up, not just the baseline measurement on the day of the exam. If the examiner writes, "Range of motion is within normal limits today," but you know that on your bad days you lose 50% of that motion, you must say, "I understand my range of motion is good today, but I want the record to reflect that 2 days ago my documented range of motion was only specific measurement due to swelling and pain." This preemptive strike against the intermittent label is vital. Let's return to the second deadly phrase. The veteran reports full capacity for daily activities, ADLs, and social to occupational functioning. This is a trap built on the veteran's natural tendency to maintain dignity and downplay suffering. No veteran wants to admit they can't tie their shoes or that their spouse has to manage their finances. However, the VA system demands this vulnerability. If the evaluation suggests you are managing your life normally, the VA will not compensate you. To elaborate on the counter strategy, we must introduce the concept of assistance and adaptation. If you can still shower, but you use a shower chair, grab bars, and require your spouse to be nearby, you do not have full capacity. You have accommodated capacity. If the examiner asks, "Do you drive?" and you say yes, you must add the caveat, "Yes, but only short distances, and only when my anxiety medication is fully effective, and I cannot drive during a flare-up of my neck pain because I cannot safely check my blind spots." The examiner is looking for simple yes-no answers that they can translate into a positive functional capacity. You must refuse to provide simple answers. Every activity must be framed through the lens of limitation. If you can walk your dog, how far can you walk? How much pain does it cause? Do you have to take a break halfway? Does it lead to an increase in symptoms for the rest of the day? The VA rater needs to see that while you may attempt ADLs, the attempt often leads to a significant increase in pain, fatigue, or psychological distress. If the evaluation fails to mention the accommodations or the negative consequences, the rater assumes full, unhindered capacity, resulting in a denial of benefits based on the lack of demonstrable functional impairment. The veteran must be prepared to detail every modification they have made to their life, proving that their current level of functioning is not normal, but a carefully constructed set of workarounds necessitated by the disability. Dissecting the third phrase. Lack of objective medical evidence supporting current complaint. relies heavily on subjective reports of pain. Requires a deep understanding of the VA's preference for hard data. When the examiner uses this, they are often relying on the absence of visible pathology, e.g., a clean MRI, to dismiss pain. The counter-strategy here is to use the absence of objective evidence as an objective indicator of the condition itself, where applicable. For mental health, for example, the absence of a structured life, the absence of employment, and the absence of social relationships are themselves objective data points that support the subjective report of isolation and anxiety. Furthermore, the veteran must leverage pain scales and medication efficacy. If you are taking high doses of potent narcotics or nerve blockers, the fact that you need those medications is objective evidence supporting the severity of the underlying pain, even if the source of the pain is invisible on an X-ray. You must ensure the examiner documents the full spectrum of pharmacological intervention you require. If the examiner tries to dismiss your pain as merely subjective, you must pivot to the functional consequences. If this pain were merely subjective, I wouldn't have been forced to quit my job and I wouldn't require assistance to climb stairs. The objective evidence is the loss of my career and my reliance on daily high-dose medication. This forces the examiner to address the functional reality rather than just the radiological findings. If they ignore the functional reality, the evaluation is legally insufficient, but the veteran must plant the seeds of insufficiency during the exam itself by providing irrefutable functional evidence. The fourth phrase, inconsistency between reported history and service records or prior medical documentation, is a test of memory and preparation. The extreme length of time between service and claim filing makes this inconsistency a common pitfall. To expand on the counter-strategy, we must address the concept of lay evidence precedence when STRs are incomplete. If the examiner notes an inconsistency because the STRs are silent on a specific injury, the veteran must immediately introduce the concept of fear of reporting or lack of access to care. Many veterans avoided sick call for fear of being labeled weak or jeopardizing promotion. This historical context is vital. The veteran should state, "While my STRs do not reflect this specific event, I have provided sworn buddy statements from names and my own detailed lay statement explaining that I managed this injury without official documentation until separation." The examiner must then consider this lay evidence. If they simply note the inconsistency without acknowledging the lay evidence provided, the evaluation is flawed. The veteran must be articulate enough to present the inconsistency not as a lie, but as a gap in military documentation that is filled by credible, consistent lay testimony. If the inconsistency is major, such as a conflict regarding combat service, the veteran must immediately provide official documentation, DD 214, unit deployment records, to clarify, demonstrating that they are transparent and not trying to mislead. The goal is to eliminate the examiner's ability to call the veteran's narrative into question. The danger of the fifth phrase, non-compliance with prescribed treatment protocols or failure to follow medical advice, lies in the VA's legal requirement for the veteran to cooperate in their own care. Expanding on the mitigation strategy, the veteran must understand that noncompliance is only excusable if it is medically necessary or caused by the service-connected condition. If the veteran stopped attending therapy because they felt it wasn't working, this is generally viewed as noncompliance. However, if the veteran stopped attending therapy because the exposure therapy triggered debilitating panic attacks that required hospitalization, that is a direct consequence of the service-connected condition. The veteran must ensure their private medical records clearly delineate the reason for discontinuation. A simple note from the primary care provider stating, "Patient discontinued X due to intolerable side effects is powerful. If that documentation doesn't exist, the veteran must use the C&P exam to create that documentation, clearly explaining the medical or psychological rationale for every missed dose or canceled appointment. Furthermore, the veteran must demonstrate a commitment to alternative symptom compliance. If they stopped physical therapy, did they start a home exercise program? If they stopped one medication, are they trialing another? Non-compliance is less damning if the veteran can show they are actively seeking other ways to manage the condition, proving that the desire to mitigate the disability is present, but the specific treatment protocol was incompatible. The sixth phrase, symptoms appear exaggerated or theatrical during the exam, is rooted in the examiner's clinical observation of symptom magnification. To effectively counter this, the veteran must adopt a demeanor of detached clinical objectivity. When describing pain, use medical terms rather than emotional ones. For example, instead of saying, "The pain is like 1,000 knives stabbing me," say, "The pain is a sharp burning sensation that registers an 8 out of 10 on the pain scale, and it radiates from my lower back down the lateral aspect of my left leg." This clinical language is harder for the examiner to label as theatrical. Furthermore, the veteran must maintain consistency across all aspects of the exam. If the veteran claims they cannot sit for more than 5 minutes due to back pain, they should not sit comfortably for 30 minutes during the interview. They should periodically shift, stand, or request to adjust their position, demonstrating the limitation without being overly dramatic. Examiners are specifically trained to look for discrepancies between the veteran's self-reported functioning and their observed behavior. If the veteran reports severe depression and isolation but is impeccably groomed, highly articulate, and engages in constant warm eye contact, the examiner may flag this as incongruence. The veteran must ensure that their presentation is truthful to their actual state, even if that means appearing visibly distressed or unkempt, provided that is the reality of their condition. The key is authenticity and consistency. If the evaluation includes this exaggeration flag, the rater will often dismiss the entire claim, believing the veteran is attempting to defraud the system, an accusation that is almost impossible to overturn without a full re-examination. Finally, reinforcing the fight against the seventh phrase. Condition is better explained by non-service-connected etiology. This is the nexus challenge. The veteran must understand that the VA does not require service to be the only cause, only a cause. If the examiner tries to blame aging for arthritis, the veteran must provide evidence of the service-connected event, severe physical training, injury, or documented joint strain that initiated the process decades earlier. The concept of acceleration or aggravation is crucial here. If the veteran had a pre-existing minor condition that was made significantly worse by military service, the VA is responsible for the degree of worsening. The veteran must explicitly instruct the examiner to consider the aggravation standard. For instance, yes, aging contributes to arthritis, but my service-connected airborne duties and multiple hard landings accelerated the deterioration of this joint far beyond what would be expected for a person my age. This forces the examiner to address the nexus in terms of acceleration rather than simply dismissing the condition as a natural consequence of time. If the examiner ignores the service-connected event entirely and focuses only on post-service factors, the evaluation is legally inadequate, and the veteran must be prepared to challenge it immediately with a supplemental claim or appeal, armed with the knowledge that the examiner failed to consider the full history. In conclusion, understanding the coded language of VA evaluations is the most powerful tool a veteran has in the claims process. The C&P exam is a high-stakes adversarial encounter, and the evaluation report is the final battlefield. These 7 phrases: intermittent symptoms, full capacity for ADLs, lack of objective evidence, historical, inconsistency, non-compliance, perceived exaggeration, and non-service connected etiology are not just observations. They are pre-written denial codes. Your preparation must be exhaustive. You must know your records better than the examiner, anticipate the traps, and proactively insert the necessary mitigating context for every single symptom and limitation you discuss. Never give a simple yes or no answer. Always qualify your functioning with the pain, effort, and accommodation required. Be honest, be consistent, and be clinical in your descriptions. By understanding how the VA system seeks to minimize or deny your claim through these specific linguistic maneuvers, you can control the narrative, block the denial codes, and ensure that the final evaluation accurately reflects the true, debilitating reality of your service-connected condition, leading to the compensation you have earned and deserve. Do not let them write your denial for you. Take control of the record and fight for the benefits that are rightfully yours.